right, now I'm good. Sonia, are those students, you're looking at the screen, are they coming into the lobby? Do I have to do anything?
No, I've let them in.
Okay, then I'm good. All right.
So,
Well, sorry for the technical difficulties. Hopefully all of you are here since it's 3 minutes after 10:30, 12:30 your time. For week 6 here, I had a few things I wanted to go over. Dr. Ward mentioned last week that umbilical cord Dopplers are a little confusing. So I wanted to spend a little time reviewing these with you, not as a sonographer, but as a nurse or physician trying to understand the concepts so that you understand what the tools can be used for. So the umbilical cord Dopplers, basically, there are 3 things that are important. There's the umbilical artery, the umbilical vein, and end diastolic flow. Those are the 3 concepts that are very important. And as you're looking at the picture, you notice that the cord again is coiled, and there's 2 arteries and 1 vein. The vein is in blue. The arteries are in blue, the vein is in red. The umbilical arteries, the flow is going away from the fetus, and the umbilical vein is going towards the fetus. So bringing oxygenated blood to the fetus, which is opposite of an adult, which is away. Veins carry blood away from the heart, but not in the fetus. So again, the vessel, 3-cord vessel, 2 arteries, 1 vein. The vein carries oxygenated blood towards the fetus. The arteries carry deoxygenated blood towards the placenta to get oxygenated. The cord is protected as an insulator with Wharton's jelly. That's that gelatinous material that protects the cord from compression or other trauma. The placental insertion site is also very important, and that's one of the things we look at when we're doing ultrasound Doppler. The site that's most appropriate would be central. However, lots of cords head towards the margin of the placenta or are minimally attached through the membranes, and we call that velamentous. Marginal and velamentous cord insertions create problems with flow and exchange of nutrients and oxygen and waste products, and tend to cause problems with fetal growth and problems during labor. Now, when we go to the umbilical artery, we know that the resistance to flow is normally low. The umbilical vein has no flow, and it's just a continuous waveform. It's non-pulsatile. And we don't have to worry too much about the ductus venosus, but if you read about it, it's a triphasic waveform. So the whole purpose of umbilical cord Dopplers is to look at the resistance to flow through the umbilical cord towards the fetus. And this is very important. If we find high resistance in the umbilical artery, that's a concern for fetal growth, exchange of nutrients, and the possibility of hypoxia. If the umbilical artery has low resistance, then the Dopplers are usually normal. So things that could cause problems in the fetus where we would use Doppler: placental insufficiency, fetal anemia, arrhythmias, complications of twins, growth issues, mostly symmetrical and asymmetrical growth, medical complications of pregnancy, such as preeclampsia, hypertension, diabetes, both gestational and adult onset, type 1s and 2, and collagen vascular disorders, such as lupus would be one, and others. Now, we're going to go to the second thing that we do, and that's the middle cerebral artery. The middle cerebral artery located in the circle of Willis, is a vessel that normally has high resistance, the opposite of the umbilical artery. If we see low resistance in the fetal brain, in the middle cerebral artery, it means that there's brain sparing and that the fetus has shunted blood towards the brain as a protecting element. This is concerning because it shows that the baby is under quite a bit of duress. And we'll get to that in a second here. But the normal flow is important to understand, and umbilical arteries, umbilical veins are very easy to detect. And one thing that's also important is to make sure you count the number of blood vessels in the cord. It's very easy to miss an umbilical artery, an absent umbilical artery. If we're looking at these drawings, the one on the left shows a normal umbilical artery flow, systolic over diastolic ratio. It should be less than 3 after 30 weeks, after 30 weeks of gestation, and it should be less than 2 towards term. If it's higher than 3, or higher yet, it means high resistance. If you look at the image on the right, that's the middle cerebral artery, and the image on the bottom is normal. It shows high resistance with very little diastolic flow. If that would reverse, that could be a problem. That would mean, as we said a moment ago, brain sparing and problems with shunting of blood. Any questions on that? I know it's a little confusing, but we're going to talk about it over and over because in a moment we're going to use those tools for fetal testing. Remember, we talked about a toolbox for antepartum testing for surveillance. So when you hear about a perinatal or maternal fetal medicine toolbox, this is what we mean. We have Dopplers, we have fetal monitoring assessments, and that's what we're going to talk about right now. One of the easiest tests is the non-stress test. And we mentioned last week that fetuses under 32 weeks of gestation would be okay or appropriate to have accelerations of 10 beats per minute, lasting 10 seconds, 10 by 10, as we say. Whereas after 32 weeks of gestation, accelerations need to be 15 beats per minute above the baseline, lasting greater than 15 seconds. So 15 by 15. And we like to see 2 accelerations in a 20 to 30 minute time interval. That test can be done anywhere. It could be done in the doctor's office. It could be done in an antepartum testing unit. It could be done in the hospital when the patient is an inpatient on a day-to-day basis. The contraction stress test used to be the #1 antepartum testing device. However, it has really fallen back behind some of the other studies, mainly because it's very difficult to perform and it takes time and a lot of personnel. There are contraindications who could have the stress test, namely patients who've not had any uterine surgery, such as fetal surgery. If you've had 2 or more cesarean sections, you might think twice about doing a contraction stress test. If you have a placenta previa or cervical insufficiency, it wouldn't be a good idea to do a contraction stress test. So there are limitations. So what evolved over time is called the biophysical profile. And the biophysical profile, as we spoke last week, includes 4 different characteristics other than the non-stress test. The non-stress test is added to the biophysical profile. Remember, we talked that fetal breathing motions are the first to go when a fetus is under stress in any form. The second to go would be fetal tone, these tonic movements. then gross body movements, and then, of course, the amniotic fluid volume. The lower the number of vertical pockets of 2 centimeters or more usually means chronic hypoxia. So you get a score. The score of a biophysical profile, counting 2 for each parameter, plus the non-stress test, the perfect score would be 10. Anything 6 or below would be concerning. And then a modified biophysical profile evolved because, again, of time constraints. And a modified biophysical profile uses the non-stress test and an ultrasound looking at the amniotic fluid volume. If the volume shows normal amniotic fluid, and I usually use 5 as a cutoff with non-cord pockets of fluid. If it's 5 or above and the non-stress test is reactive, then the modified biophysical profile is complete. If, on the other hand, the non-stress test is non-reactive or suspicious, and or the amniotic fluid volume is low, then a full biophysical profile and other testing may be indicated. There's a lot of talk that you never want to do Dopplers on healthy fetuses because we don't know what that means. So it's saved for abnormal clinical parameters, not normal. I also want to spend a few moments talking about definitions. They're very confusing. One is hypoxemia. To me, hypoxemia is a decrease in oxygen in the blood. Sustained hypoxemia or sustained lack of oxygen in the blood means that delivery of the oxygen to the tissue is limited. If it continues, it results in hypoxia. Normally, when oxygen is available in the umbilical cord through the placenta and through to the fetus, we get aerobic metabolism. Energy is produced in the form of ATP, which results in byproducts of metabolisms, carbon dioxide and water. The carbon dioxide is dissipated through the umbilical cord into the maternal circulation, and when the mother takes a breath, most of that carbon dioxide is gone. When oxygen is in short supply and the tissues are forced to convert energy from aerobic metabolism to anaerobic metabolism, lactic acid is the byproduct. And when it's produced in the tissues at a high level, we have metabolic acidosis. Lactic acid accumulation utilizes buffers such as the hydrogen ion and the bicarbonate. It creates the hydrogen ion, and the bicarb is used to buffer it. When we run out of the bicarb buffer and we have too much hydrogen ion, the pH falls, and that creates metabolic acidosis. I know this is a little confusing, but if you think more hydrogens, lower pH when the buffers are used. So when we look at a blood gas on a fetus, a lot of times we want to look at whether we have a respiratory or a metabolic acidosis. One of the key levels to look at is the carbon dioxide and the bicarb. If the carbon dioxide is very high, more than likely it's a respiratory acidosis. If the bicarb is very low, that means it's been utilized to neutralize the hydrogen ion, and if it's utilized too much, it will result in a metabolic acidosis. So these are important because lactic acid is fixed, and once it's there, it's very difficult to remove from the tissue. And fetuses that reveal lactic acidosis usually have fetal compromise and abnormal labors, late decelerations, category 3 tracings, and have problems with potential neurologic impairment. So I just wanted to go over those few things with you to make sure they're clear, and we'll talk about them over and over as time goes on because I know they create some discussion and distress. I'm going to go back to content here a second. The other thing I wanted to go over with you is this little fetal assessment and safe labor management. This monograph is produced by the National Certification Corporation, NCC, and they are an important body for nurses when it comes to fetal monitoring, labor and delivery principles, and excellence in obstetrical care. And they also are experts in neonatal management, pediatric care of the fetus once the baby is born. So I want you to make sure you review this, and there are some very important definitions and terminology. And the important thing is that we're all on the same page with this language. So if you work in labor and delivery or you do your clinical rotation, this is the language you're going to be expected to use and understand in terms of variability, accelerations, decelerations, and it goes through some of the pathophysiology, what creates accelerations, decelerations, where the sympathetic nervous system and the parasympathetic nervous system is involved, baroreceptors and chemoreceptors, which are always very confusing, and some of the physiology, what causes what in terms of maintaining blood pressure, strengthening of the cardiac contractions, the cardiac output. These are all very important. We talk about sleep cycles and on and on. And it's very important that you understand some of these parameters. So I encourage you to review this over and over. It talks about the different categories, how to classify them, intrauterine resuscitative measures, which are so important during labor. There's also a little pocketbook that is produced by one of the authors that I like. Her name is Lisa Miller, and it's called The Pocket Guide to Fetal Monitoring. And if you can get your hands on a used copy, it's really a good book to carry around with you. Nurses use that all the time. Physicians use it as well, or at least they should. But it basically covers the importance of what to do when there's a concern. And it gets back to, where does the oxygen come from on the maternal side of the equation, on the placental side, and to the fetus? How could you enhance fetal oxygenation through the umbilical cord, through the placenta, and through the mother? So if the mother has pneumonia, COVID, or has pulmonary edema, you could see how it could affect oxygen exchange at the placental level, the intervillous space, and then how the fetus might be affected both acutely and chronically. So I encourage you to look at this. Uterine activity is important. There's always concerns about how to measure strength and intensity of the contraction, resting tone, and also frequency of contractions. And then it talks about some statistics on vaginal birth and cesareans. It also talks about the progress of labor, which is also important because things have changed recently as to what is active labor, what is the first and second stages of labor, how long a prima gravida and a multigravida can push, whether they have epidurals or not, and then oxytocin protocols. And this is a really good review of all of this. And then it talks about patient safety in the hospital. And I really encourage you to look at this. And we're going to be reviewing this topic a little later in the sessions, but culture of safety is so important. And these last little monographs here really go over this. So I encourage you to review that. Let's go back here. I'm just going to stop talking for a moment if anybody has any questions for about 30 seconds. And then what I want to do today is spend a little time going over the fetal heart rate monitoring exam today. Even if you didn't do it, doesn't matter. See if I can get it going. Maybe.
Dr. Levine, are you sharing your screen?
I am not sharing my, well, I hope they're seeing the screen. Are you seeing it, Sonia?
No, I have actually been sharing my screen and trying to follow along.
So you're not seeing my questions that I have up?
Mm-mm.
Oh dear. What should I do? Let's see.
Can you click that little icon to it's like looks like a box with an up arrow?
Let's go back here. I think that's not going to do me any good. Let's see what I have here. Oh boy, that's not working. I thought I had the screen going and everybody was seeing it.
I was sharing my screen and showing
Oh.
the PDF that you were discussing.
Oh, good. Thank you. But now I am not getting anywhere here.
Okay.
Let's
Do you have
see.
the icons at the bottom that starts with a chat bubble and then two little heads and then a box?
No. Let's get back here. I may have to start over again here.
That's all right. What I'm seeing when I look at my screen is all of the people that are in the room, like little letters for the first and last name of all the people in the room. Is that what is on
Okay.
your screen?
I am not getting anything right now. So let me just get back to Chrome here. I lost my place. I've got to go back here. I'm so sorry.
That's all right.
This is not good.
Okay, go to Teams. I want to make sure that you got your
Okay.
screen shared.
Let's get Teams. Here we go.
Okay. And now click on the third icon over from the left that has a box with an arrow pointing up.
Yep.
And then do share screen.
Sure. Got it. Let's see if that comes up. My apologies.
There we go. Now it's sharing your screen.
And it's blurred to me.
It'll take a second. It took about
Okay.
15 seconds when I did mine.
All right. Now I've
It
got to
would
get
definitely
back.
be more helpful in real time if you went through the quiz versus me trying to click for you.
Well, let's see if this works. This is still scrolling.
I mean, if we have to do it that way, we can, but I think it would be beneficial if you did it.
Oh, that's all right. I mean, I don't mind. Let's see if I can get that back here now. So now
Okay.
I need.
Now go ahead and swipe up and go to Chrome, and you should be able to get back to your course. Yay.
I'm going to have to log in here. I can't believe it. All right, I'll just log back in. Kicked me out for some reason. Sorry about that. All right, let's get back to our exam. Oh my gosh.
There we go.
All right, let's get this exam up here. See if we could try it. All right, we're going to go. Thanks, Sonia. I'm so sorry, guys. We got it going. All right, yay. First question. Doppler ultrasound velocimetry of the umbilical artery is a non-invasive technique used for. Well, hopefully we know it's not fluctuations in fetal heart blood pressure or fetal blood pressure. Could it be resistance to blood flow within the placenta? Velocity of blood flow between the fetus and the mother. So what do we think? It's more of a resistance to blood flow within the placenta. So we'll pick B. When spontaneous accelerations occur, This reflects, is it myocardial responsiveness, neurologic integrity, parasympathetic effects? Accelerations are usually an interaction of the nervous systems, so we're going to go with neurologic integrity. As pregnancy progresses towards term, it can be expected that the fetal heart rate will, remember we said, decrease progressively because of the parasympathetic influence. The other two won't help us. Recurrent late decelerations in the presence of moderate variability are considered to be a reflection of cerebral distribution of blood flow, neurologic or neurogenic in origin and amenable to intervention, transient and benign, and require no further monitoring. Well, that's kind of a tough question. It is a reflection of cerebral distribution or redistribution of blood flow and physiologic. The key to that is moderate variability. If moderate variability was absent, then that would be a problem. I don't like the transient and benign because recurrent late decelerations are not benign and they require additional monitoring. So the answer to question number 4 is A. Number 5, accelerations primarily occur in response to. This is a little challenging because it could be A, but usually it has to do with fetal movement. Accelerations are the product of fetal movement, the intact nervous system, the autonomic nervous system. Question 6, the baseline fetal heart rate decreases. This is just another way of answering the same question as couple prior, decreases with gestational age as a result of an increase in, and that's the parasympathetic tone. If anyone has any questions, please don't hesitate to say something. Number 7, the baseline heart rate of a 28-week-old fetus is 170 beats per minute. The most appropriate next step would be, well, observation is partially correct. Biophysical profile, maybe not sure that's relevant, but we want to make sure that there's no maternal fever. So 170 beats per minute is not necessarily abnormal in a 28-week-old fetus, but it does warrant the use of checking maternal vital signs. Number 8, fetal reactivity is primarily dependent upon intact central nervous system would be the answer. Number 9, fetal heart rate decreases again as gestational age increases because of increased parasympathetic tone. I just want to make sure everybody gets that. I put 3 of those on this little quiz just to kind of go over that with you. And let's see if I can get to number 10 here. An electronic fetal monitoring factor that best correlates with fetal well-being is absence of decelerations, presence of accelerations, presence of variability. Well, the best answer is the presence of variability. It requires an intact autonomic nervous system, central nervous system, and it's a little more. The second best answer would be accelerations. That's a hard one. Number 11, fetal heart rate variability is a result of the interaction of the sympathetic and parasympathetic nervous system, release of epinephrine and norepinephrine, stimulation of aortic arch receptors. The answer is A, the interaction of the sympathetic and parasympathetic nervous system. Number 12, Doppler signal transmission of the fetal heart rate can be limited by, this is a hard one because we didn't discuss it, elevated maternal heart rate, polyhydramnios, uterine contractions. Well, we have to understand that the Doppler signal is transmitted through amniotic fluid. And if there's too much amniotic fluid, the signal can be weak or not transmitted appropriately. So Doppler depends upon the amount of amniotic fluid to get to the point of origin, which is when we do umbilical cord monitoring. So, and also fetal heart rate monitoring. A Doppler of the fetal heart rate is an external Doppler, just like we use for monitoring, external monitoring during labor. So if mom has too much amniotic fluid, the signal will be weak. So hydramnios is the answer there. The significance of fetal sleep cycles are that they can be, and that's clear, they can be mistaken for non-reactivity on a non-stress test. Normally decreased fetal heart rate, fetal movement for up to 60 to 90 minutes is a little too long to wait. Results in marked variability, that's not correct. So the important thing is that we understand that it should not be mistaken for non-reactivity on a non-stress test. And the way to change that would be to use either a stimulation like sound, a vibroacoustic stimulation, or scalp stimulation, or making a noise, trying to wake the fetus up. Number 14, when a woman in labor is supine, a common response would be a decrease in, well, what happens when the mother is laying on her aorta and vena cava? The vena cava gets compressed more than the aorta, and it's going to decrease cardiac output, which eventually would decrease uteroplacental blood flow. But the best answer is maternal cardiac output, followed by uteroplacental blood flow. Question 15. A fetal circulatory response to hypoxia is a redistribution of cardiac output, which maximizes fetal lung oxygenation, preserves blood flow to vital organs, regulates blood pressure fluctuations. But we spoke about this, that a fetus that's under hypoxic stimuli or concerns will redistribute blood to the vital organs. So the brain would be one, the adrenal glands would be the other, the heart would be the third. So it preserves blood flow to vital organs is the logical answer. Next question, 16. Late decelerations that occur as a result of epidural anesthesia are due to aortovenocaval compression, the level of sympathetic blockade, uteroplacental hypoperfusion. These are all interesting answers, but the logic behind this is late decelerations are occurring already, and that means that we have poor placental perfusion. And it's because of vasodilation, not aortovenocaval compression, and not because of sympathetic blockade. Sympathetic blockade could cause vasodilation, but it's the uteroplacental hypoperfusion that causes the late decelerations. Number 17, the fetus can tolerate a lower PaO2 than the adult because of higher blood volume, increased oxygen carrying capacity, lower cardiac output. Well, if you think about it, a fetus has a different hemoglobin in utero than the adult. It's called hemoglobin F. And the beauty of hemoglobin F is it has a higher oxygen carrying capacity. That is a greater affinity for oxygen, and it can carry the oxygen to the tissues in a much more efficient capacity. So the answer is increased oxygen carrying capacity. And that's an important concept, why a fetus can be in utero with a much lower PaO2 than an adult and still be happy, moving around, not having any effects of low oxygen. Number 18. The majority of uterine blood flow supplies what? The fetus, the placenta, the umbilical cord. And the answer is the placenta. Approximately in a term uterus, the blood flow to the organ and to the placenta is over 500 milliliters per minute. And that's very important to remember, because if there's uterine hemorrhage from an abruption or during surgery, you could lose a significant amount of blood in a hurry. So the placenta gets the majority of the uterine blood flow. The intervillous space is again important because that's where blood flow is used for exchange from the fetus and to the mother. The question is, intervillous space circulation is maximized when the pregnant woman is in early labor, the third trimester, lateral position. Well, it is maximized in the lateral position, but it's also maximized in the third trimester. That's when uterine blood flow is at its highest level. So the third trimester would be the answer. If the question had to do with labor, lateral positioning would maximize uterine blood flow. Number 20, an internal electronic fetal monitoring tracing continues to record artifact despite equipment troubleshooting and replacement of the spiral artery. The next action is to what? Auscultate the fetal heart, notify the neonatal team, reposition the woman. Well, the logic is, if we're having technical problems with the tracing and we've done all we can do with the equipment, the next step would be to confirm that the fetal heart rate is not showing signs of arrhythmias, either bradyarrhythmia, tachyarrhythmia, or some abnormality. And the way to do that is auscultation. Usually you've repositioned the patient a number of times during the troubleshooting and replacement of spiral electrodes, etc. So the best answer again is A, auscultate the fetal heart rate. Number 21, when using a toco transducer to monitor contractions, intensity and resting tone are assessed how? Graph recording, millimeters of mercury, palpation. So this question looks at some important concepts of fetal monitoring. When you have a toco transducer, we're looking at an external monitoring belt. And the only way to measure intensity and the resting tone is the use of palpation. The other two will not help you with an external tracing. Number 22. In the fetus, parasympathetic impulses originate in the brainstem and are carried to the heart by the what? Cervical sympathetic fibers, stimulation of cardiac beta receptors, the vagus nerve. Well, the parasympathetic nervous system is a great deal the vagus nerve. So that is the answer. Number 23. For a fetus at 26 to 27 weeks gestation, a heart rate acceleration of 10 beats per minute above the baseline lasting greater than 10 seconds is interpreted as abnormal, indeterminate, or normal. Remember on that earlier question that a 27-week fetus had a heart rate of 170, Is it abnormal? Well, this is a similar question. And remember, we talked about that under 32 weeks of gestation, if we're doing a non-stress test, 10 beat accelerations lasting 10 seconds or greater are considered normal. So the answer to question 23 is normal. Number 24, the tocodynamometer provides information about the uterine contraction pattern by detecting. Now, this is a tough question. It has to do with a physical law of Poiseuille. So if you're interested in physics of how this all came about, it's the measurement of an ellipse. And energy output is not really appropriate. Muscle strength during the contraction, you'd think would be correct, but it's the shape of the uterine wall that's really looked at. And again, it's by Poiseuille's law of an ellipse. That's kind of a tricky question. Number 25, the primary value of electronic fetal monitoring is to identify the fetus who is not apoxic, to prevent cerebral palsy, to reduce perinatal mortality. If you look at all three, you kind of shake your head and say, well, maybe, but that's not the case. The case for electronic fetal monitoring is to identify a healthy fetus, the fetus who is not apoxic, and that's the answer. Fetal monitoring cannot prevent cerebral palsy, and fetal monitoring per se may not reduce perinatal mortality. It should, but statistically, it has not been shown to do that. Question 26. The direct method of fetal heart rate monitoring uses Doppler, spiral electrode, ultrasound. Well, direct is a spiral electrode. Number 27. While late and variable decelerations have similar characteristics, the major difference relates to what? The depth of deceleration, the duration, the timing of onset. So the difference between late and variables, there are a couple of them. One is late is a gradual decline in the fetal heart rate. However, it usually occurs after the peak of the contraction. A variable deceleration is an abrupt decrease in fetal heart rate. And when you compare late and variable, the difference is the timing of onset. And that's the importance of this question, to know that. Number 28. The underlying physiology of early decelerations is baroreceptor response suppression, increased peripheral resistance, vagal stimulation. This is a challenging question because early decelerations are a mirror image of the uterine contraction. They were identified by accident in the neonatal intensive care unit. What had happened was neonates with IVs that were placed in their head, which wasn't uncommon before umbilical catheterization, would result in some physiologic changes in the heart rate when they used a donut to protect the IV, and it surrounded the soft spot of the fetal scalp. And if they projected that, whenever you compressed that donut, you had a lowering of the heart rate. So when the cervix is roughly 4, 5, 6 centimeters in dilation, and the station is very strongly compressed against the fetal head, is the vertex is against the cervix at a 0 or better station, it causes a deceleration because of pressure. And it is a vagal response that causes the pressure and results in a deceleration that mirrors the uterine contraction. The heart rate and uterine contraction mirror each other. Vagal stimulation is the answer. If I didn't explain that well, I'll try it again when we meet. Question 29. The success of interventions to treat fetal hypoxia first depends upon improving maternal oxygenation, minimizing uterine activity, optimizing uteroplacental blood flow. Well, those are all good answers, but optimizing uteroplacental blood flow is probably the most important issue. Improving maternal oxygenation clearly helps, but if you don't have good uteroplacental blood flow, you're not going to help fetal hypoxia. So the answer is optimizing uteroplacental blood flow. Number 30, intrapartum baseline heart rate of a fetus at 41 weeks gestation is 110 beats per minute with moderate variability. These fetal data warrant continuous electronic fetal monitoring, intrauterine resuscitation, routine intrapartum care. The answer is this is normal at 41 weeks because of the influence of the parasympathetic system, which would lower the baseline to 110 to 120 beats per minute. So you would see a baseline at the lower range of the normal range of 110 to 160. Therefore, the answer is routine intrapartum care. 31, changing maternal position to remediate variable decelerations is primarily done to decrease uterine activity, promote maternal oxygenation, relieve cord compression. So, changing maternal position from side to side with variable decelerations are used because variable decelerations usually are indicative of cord compression. So by moving the patient side to side, sometimes it will dislodge a cord that might be up against a fetal part. However, if it's a cord around the neck, it won't help. If it's around a limb, it might help. So the answer is to relieve cord compression. 32, our final question. Usually the duration of an early deceleration in comparison with the contraction is, and we just talked about that, it would be the same. It mirrors the contraction. So the contraction and the heart rate are together, and that means the same. Any questions on any of those? No one has any questions? Okay. All right. Well, I just want to give you a couple more tidbits of information. I've read a lot of your topics, and they're very good. I'm interested to hear some of the interview questions next time that you put down, and also some of you are ready to do the interview, and that would be great. The interview, the questions, and your references, the source are due in a couple of weeks, but I would encourage you to get that done pretty soon. We have the 27th as the deadline for that. So if you're going by that deadline, great, but I know a lot of you have submitted your questions already, and I've looked at them, and I'm very intrigued by a majority of the topics. Next week, there was well, it was released by the ACOG. It was a practice bulletin for gestational diabetes. We're going to have to get another copy because some of the pages were left out. So my apologies we'll have that for you for next week, but we won't get to it until week 8, because next week we want to spend a great deal of time on the different hypertensions, and it's going to take the full hour to go over those. So I encourage you to review hypertension, get your interview questions and topics complete, and gestational diabetes, the ACOG practice bulletin number 190, we'll get that redone so you could use that. It's really a good one. Even though it's a few years old, it's one of the better ones that I've seen, and it has so much good information for gestational diabetes. I know a couple of you have chosen gestational diabetes for your topic, so this is a good way of getting a beat on it. A lot of that information you need will be in that ACOG practice bulletin. There's also others that are available through ACOG, and if maybe I could help you get some of that information. But I think you're doing a great job choosing your topics. I think some of the content we're going over will help you with some of these topics of interest, and we'll definitely talk about hypertension and some of the complications such as preeclampsia and PRES, which is fascinating. So I know we have about a couple minutes here. If anybody has any questions, I'll be more than happy to answer them. Otherwise, we'll be meeting next week again online, and we'll go from there. So if I don't hear in another minute, I'll say have a good week, and if I could answer any questions online, or you have a question regarding your interview or your questions, please don't hesitate to hold on. Just ask me.
I think Maria is entering a question in the chat.
All right, could you help me with that? Because I can't pull that up right now, Sonia.
Okay. You can switch back to looking at Teams.
I sure can.
Oh, she was just saying thank you.
Oh, okay. My
That's
pleasure. Fine. Thank you, everybody. All right, we'll be again meeting next week at the same time. Thanks again. Bye now.
Thank you.
Thank you.